Hello, I'm Chan-ho Lee from Indian University Busan Hospital in Korea. As the first author of this study, I would like to provide a brief introduction related to this study. The listed authors are the researchers who participated in this study, and the corresponding author of this research is Professor Hong Ha from Busan National University Hospital. This is background of our study. Recently, androgen receptor pathway inhibitor ARPI-based doublet or triple therapy has become the standard of care for mHSPC. However, reports regarding the outcome of treatment intensification using ARPIs in real-world clinical practice and how ARPIs should be selected for specific patients are scarce. Page 3 clinical trial-based meta-analysis shows that abiraterone acetate was slightly effective than apalutamide or enzalutamide in charted high-volume disease. Due to the lack of head-to-head comparison, we identified evidence through this retrospective study. The study population consisted of 219 patients from 4 Korean institutions who were treated with abiraterone, apalutamide, or enzalutamide. The study analyzed treatment outcome based on the use of each medication. The primary endpoint was mCRPC progression-free survival according to ARPIs. Secondary endpoint consisted of progression-free survival according to tumor volume, early PSA response, and side effect differences. Early PSA response means PSA decreased of 90% and PSA declined to 0.2 nanogram per milliliter within 12 weeks after ARPI induction. This is the baseline characteristics of patients. The median duration of medication was approximately 19 months. The abiraterone group shows a significantly longer duration of ARPI use, and their median initial PSA level were also higher. The site of metastasis were similar across groups, but the number of bone metastasis was significantly higher in the abiraterone group. In terms of risk stratification, the abiraterone group included more high-volume and high-risk patients. The primary endpoint was mCRPC progression-free survival. As we can see here, mCRPC progression-free survival was the same for all type of ARPI in all patients, latitude high-risk patients, and charted high-volume patients. The 2-year mCRPC progression-free survival was over 70% in all patients. When we analyzed PSA response within 12 weeks after starting ARPI treatment, apalutamide and enzalutamide had a faster and deeper PSA response compared to abiraterone. However, all ARPIs achieved over 90% PSA reduction from initial PSA after ARPI treatment. When we look at the survival differences according to early PSA response, patients who achieved early PSA responses shows better survival benefit compared with those who not achieved it. When analyzing factors affecting mCRPC progression, it was found that patients with Gleason grade group 5, liver metastasis, or poor early PSA response had a higher likelihood of progressing to mCRPC. Finally, when analyzing drug-specific side effects, the apalutamide group showed significantly higher rates, leading to more frequent dose reductions due to these adverse effects. This is our study's conclusion. No significant difference in mCRPC progression-free survival was observed among ARPIs in all patients, high-risk patients, or high-volume patients. Regarding side effects, a higher rate of adverse events and treatment discontinuations was observed in patients treated with apalutamide, which aligns with the increased instance of ratio-related side effects in Asian patients. Early PSA reduction was associated with a better mHSPC progression-free survival regardless of tumor volume. Our study have some limitations such as a short median follow-up period and its retrospective design. However, it is meaningful because it reflects real-world clinical data. Additional studies with a long-term follow-up are required to further evaluate the survival benefits of ARPIs and their long-term outcomes. Thank you.